Now that we've discussed some common categories of mental disorders, let's take a look at some of the common symptoms. And I'll preface my remarks here by saying there is some repetition and review from some of the stuff we've talked about before, and that these are not in any particular order. In some cases, they're grouped in ways that I have done intentionally, and I'll describe why, but these are not in any particular importance or ordered based on their prevalence or seriousness. The first grouping we want to talk about are delusions, delirium, and dementia. And you may wonder why I've grouped these three things together. If you do wonder that, you probably know a little bit about what they actually mean. But many folks don't, and I think it's partly because they sound somewhat similar at the beginning of the words, the DE. But I also think it's because the way the media and the public in general use these words is often misled. So for example, we hear each other referring to people as being delusional, delirious, or demented almost interchangeably, when in fact from a psychological standpoint these words mean quite different things and point to different types of disorders. So our first are delusions, and delusions are firmly held but false beliefs. It's evident to everybody but the subject that these beliefs are not accurate, but the individual continues to hold them with a considerable strength of conviction, and they in fact become, in many cases, a core belief. The individual's life starts to cycle around. Some of the common delusions that exist out there include delusions of grandeur, where the person believes they're a person of much higher influence than is actually true, and in some cases people believe specifically that they are religious entities such as Jesus Christ, or political figures such as the president. Delusions of persecution are also quite common, and in these people believe that others are out to get them, that others are pursuing them or watching them, or that they're being made to pay some sort of a penalty or price for something they perceive that they have done wrong in a previous part of their life. Delusions of thought control are also relatively common, and as the name suggests, the person believes that somebody externally is putting thoughts into their head. Sometimes they believe the individual has implanted a device or found some secret way of getting these thoughts into their head. And sometimes people have delusions of reference, and this is where they believe that others are talking about them, and this may include the media talking about them. They may watch the news or read a newspaper and believe that there are secret codes or expressions throughout that piece of media that are referencing them or even telling them to do certain things. Some folks have delusions of ill health or poverty, and here they believe they are sick when they clearly aren't, or believe that they're poor when they clearly are not. Delusions are normally associated with psychosis and schizophrenia, as I said, whereas our next one, delirium, it can be found in a number of different etiologies or causes. Delirium is a transient state. It is usually short-lived, and it refers to an acute sense of disorientation and confusion by the subject. This can be caused by substance abuse, by fever, by head trauma, by seizure activity, or by excitement and agitation. For example, we've heard stories in the recent media about how individuals who were engaged either in conflict or in drug use, when encountering the police or other first responders, escalated to a level of agitation where they became completely disoriented, behaved in very erratic ways, and in some cases, after being controlled by the police, actually died from apparent asphyxiation or essentially an exhaustion of their system, I should say. When people are delirious, they are at a point where they are still physically responsive, but mentally they are not in connection to their surroundings. They don't really know what is going on. And this can sometimes show up as a person being stuporous and not responsive to questioning or social interactions, but it can also go to the other extreme where a person is engaging in sort of hypermotor activity or emotional agitation, and sometimes people can fluctuate in and out of these. And delirium can be a part of any number of disorders, and it can be a response even to medications. Dementia is our third one, and you often hear people refer to others as being demented, suggesting that the word somehow means that an individual's thought process is aberrant. Well, dementia actually refers more to a process of cognitive decline. The individual with dementia starts to lose some of the cognitive and executive functions of their mind, and we'll talk more about that later on. But the most prevalent of these symptoms of decline is the loss of memory. And you'll see that most often first and most prominently in people with this diagnosis. Dementia is often associated with aging, but it shouldn't only be associated with aging. It can really occur in anybody who has a neurocognitive disorder, any kind of disease that can affect the brain. The next symptom I want to discuss, and it's for no apparent reason, is depersonalization. This is not actually a terribly prevalent symptom, but it is a symptom that sometimes is hard for other people to sort of recognize and relate to. It's a dissociative symptom. It's often a part of a dissociative disorder, although people can actually have depersonalization as a result of other influences, again including substance use. But an individual, when they depersonalize, feels as though their consciousness, they're sometimes referred to, they self-refer to it as their spirit, is somehow separated from their body. And of course we normally think of these things as being seamlessly integrated. Sometimes people describe themselves as having these out-of-body experiences or dreams where they were looking down on their body. And other times people have a hard time simply expressing exactly how this feels. They simply say things like, I don't feel like I'm myself, or I don't feel as though my spirit is contained in my body very safely or soundly. So this can be odd. It's not a terribly common symptom, but that is a symptom of mental health disorder. Tics are our next symptoms, and tics can come in two categories, simple tics and complex tics. Simple tics are tics that normally have sort of one phase of behavior. These often show up as sounds, such as grunts, snorts, or squeaks, such as or that sort of thing. Or they can be physical behaviors, such as shrugs or jerks of the face or of the jaw. The person may do a clap, that sort of thing. But typically we see these behaviors happening extremely quickly, and really they're kind of one thing. Sometimes people make the sound and the gesture at the same time, but that's still considered to be a simple tic. For example, a person might flex their jaw and make a sound like "oh" all at one time, and that would be an example of a simple tic. Complex tics occur when you start to see trains of these behavior, or series of these behavior, and sometimes they don't look at all like an involuntary behavior. An individual, for example, I worked with somebody who would go up and slap strangers. I read another case where an individual jumped up and would go and damage his own property, and in fact one day almost damaged a very expensive painting and managed to contain himself at the last moment. Another individual I worked with would, when he didn't think anybody was watching, allow his tic energy to just come out of him, and sometimes if we watched him on videotape later on, we would see him jump up, do essentially a small dance, and sit back down, even though he's in the room entirely by himself, and there was no context for that behavior. Now, we normally associate tics with Tourette disorder, but there are other disorders. Anything that's kind of a neurological disorder could in fact have as a side effect tics, and these include sometimes people going through medication side effects or withdrawal, and sometimes people experience these tics in a transient way. For example, transient tic disorder is commonly diagnosed in young people, where for a period of some months, maybe even more, an individual may do some of these behaviors, and we believe it's because they're going through a very rapid neurological development. Other people may experience tics, for example, under stressful circumstances, and you may have a small variation on some of these yourself. You may feel a part of your body quiver, for example, when you're really stressed, and we believe that may be somewhat connected. Now, tics can be described as being involuntary behavior, but they are conscious. People are aware of their tics. What's different is that most people cannot control them even though they're aware of them. And for the layperson, we often cannot wrap our heads around the idea that a person knows they're doing something but can't stop themselves from doing it. There are people who can have a limited amount of control of their tic energy or their tics, but they have to find a way to get rid of that tic energy in a short period of time later on. If they don't, if they kind of bottle it all up, sometimes it can be manifested as more severe episodes of behavior or more dangerous complex tics. Oh, one more thing about tics. Many people believe that the tics are in the form of swearing, or what we call coprolalia. But in truth, only about 10% of people who have Tourette disorder exhibit their tics in the form of swearing or other coarse language. It's much more common for people to do the shrugs and sounds I spoke of earlier. Obsessions and compulsions are going to be discussed together. They are commonly associated, as you might have guessed, with obsessive-compulsive disorder. And there's a personality disorder, also called obsessive-compulsive personality disorder, that is similar to, but not identical to, obsessive-compulsive disorder. Obsessions are fixated thoughts. They're patterns of recurrent thought that start to take over for a person. They could be manifested, for example, as an obsession about a person, and we've probably all heard about individuals who stalked celebrities, for example. Or they can be manifested as obsessions can be also manifested as persistent thoughts about particular concepts or things. For example, we have all probably heard about Howard Hughes, who was very much obsessed with germs and hygiene, and that's actually quite a common obsession that exists out there. Compulsions are behaviors that the person has an almost irresistible urge to perform, and they can be things like hand washing or doing things in particular routines or in particular multiples. You may hear people saying they can only do things in odd numbers or they can only take a particular route. And sometimes people's obsessions and compulsions come together, so they may be fixated on a person and compelled to follow the person. They may be fixated on germs and compelled to wash their hands many, many times a day. And the obsessions and compulsions begin to override other things in the person's life, and this is what makes them so dangerous and dysfunctional. So sometimes I hear people say, I must be obsessive because I cannot leave without really, making sure that everything in my house is taken care of. Well, obsessions and compulsions really are extraordinarily prevalent in the person's life. They are far more disruptive than the idea that when you leave the house, you may think to yourself, did I leave the oven on? The person who's obsessed literally would have to turn around and go home and check their oven and make sure that it wasn't on, and in some cases may check it multiple times. So we need to understand that OCD is more than just a pattern of behavior that many of us are familiar with. It becomes an overriding issue in a person's life. Hallucinations we spoke about a little bit before. Hallucinations and delusions often come together, but they're not the same thing. Hallucinations are false sensory experiences. Now, we commonly think about the person who's schizophrenic as having auditory hallucinations. In other words, they hear things, often voices, that aren't real. Or visual hallucinations, where the person may see things that aren't real. But the truth of the matter is that many hallucinations integrate all of our senses and become extremely realistic to the individual. And when we're dealing with an individual who's going through hallucinations and ask them to distinguish between the false sensory experiences and the real sensory experiences, we're asking a lot of them because they are relying on the exact same evidence that you're relying on right now as you listen and watch. You're using your senses to provide you what you believe are actual experiences. So for the person who's hallucinating, that can be a very difficult thing. People can hallucinate for reasons other than schizophrenia. They can have psychosis caused by a variety of different things, including drugs or withdrawal from drugs, just to give you a couple of examples. Next, let's talk about some symptoms that are often more subtle for people. The first is lethargy, and lethargy isn't just purely a psychological term. We use it to describe whenever a person is lacking energy or drive, and it's often a symptom of mental health disorders across the spectrum. Many of the people that we'll support with mental health needs will actually have difficulty becoming motivated, particularly in their self-care, and sometimes this is actually a side effect of their medications. It's not just the underlying mental health disorder itself. So lethargy refers to people who are lacking that drive, that energy. Sometimes these people are casually and frankly not very accurately referred to as being lazy, when actually what's going on is they're just finding it difficult to derive pleasure from things that normally were pleasurable or energy for things that normally were of interest to them in the past. And this may be manifested in a variety of ways. One of the places we may see a person having a disruption is in their sleep. Some people sleep more than they would normally do, and this is commonly seen in people who are depressed, while others may sleep far less, and this is commonly seen again in depression actually for some people, or in the opposite of depression, an elevated mood state called mania. Some people will also find that they sleep less as a result of substance use. For example, crystal methamphetamine users may go for 3 or 4 days without sleep, and that lack of sleep in and of itself really augments their mental health conditions, makes it worse, in other words. Some people have erratic sleep patterns, being sleepy at inopportune times and being awake at times when others would normally want to be sleeping. Libido refers to the sex drives of an individual, and again, these may be depressed in a depressed person, and they may be elevated, this sex drive, in a person who's manic or who may, for example, have taken a drug such as cocaine. And people may have changes in other appetites, including their food appetites. So some people eat more, some people eat less, and some people will be a bit of mixture of both and will have erratic changes in their appetites. Self-medication is a secondary mental health symptom, and what that means is it's not the very first thing that is a symptom of the mental health disorder, but it reflects the fact that there may be other symptoms and the individual is using the medication to address them. And by medication in this case, we don't literally mean prescribed medication. We mean drugs or substances that the person accesses without the direction of a physician. And these may be illicit drugs such as cigarettes or coffee or alcohol, or illicit substances such as narcotics or even prescription drugs that are not prescribed for that individual. So the self-medication can sometimes be a really big clue that there's something going on underlying for that individual, and this becomes particularly important when dealing with a person who either won't or is not capable of expressing in detail what their symptoms are. So if you're working with somebody, for example, who has a communication deficit, you can sometimes look at the substances they're using as a sign that there may be the other things going on. For example, if we saw an individual using a considerable amount of caffeine, that's a stimulant, it may suggest that their mental health symptoms indicate depression or a lack of energy. And the opposite is true when a person is using a depressant, and alcohol, for example, a form of alcohol, then alcohol may be an indication that the individual is trying to reduce a feeling of agitation. Some people have what we call suicidal ideations, and suicidal ideations means that a person is having persistent thoughts or even planning or even idealizing suicide. And these are not just simple in saying, I thought about suicide the other day. These are often a person having a persistent and recurring thoughts of suicide. Often these suicidal thoughts are where the person is perceiving suicide as a desirable outcome, as a way of relieving their symptoms. And in some cases, people are literally plotting their suicide. And one of the things we put up as a link earlier, and I'll try to put it back up, is the diagnostic process that's put out by Ministry of Health that can be useful. It came to that Karma website we discussed earlier. It can be useful in helping us to analyze early on how significant a person's drive is towards potential suicide. As we said, some people will experience their psychological symptoms as physical or physiological symptoms, and this is referred to as somatic symptoms. So a person may, for example, have the symptoms of an illness, or they may have pain. And in the case of something like a paraphilia, we could argue that a person is also, again, having a physical response to a psychological phenomenon. So the person is becoming sexually aroused as a result of the exposure to something that to them is uniquely sexually stimulating. Now, this isn't a somatoform disorder. It doesn't fit in that category. These are still paraphilic disorders. But in any event, they are still an example of the physical manifestation of a psychological phenomenon. Catatonia. When we talk about people who are catatonic, we can think of a person who is essentially frozen or stuporous, but some people actually engage in hypermotor activity. This is often associated with disorders such as schizophrenia, dementia in its advanced stages, or even as a side effect of certain medications. The person who's catatonic may not be responsive to other people. They may sit and be impassive, may stare into the distance, and may seem as though, in some cases, the person is literally being defiant. I've worked with individuals who are catatonic off and on, and so staff people often struggle to understand why that individual wasn't responding right now, but in 10 minutes the individual was responding. So some people who are catatonic can be very, very confusing, and as I said, they can go from being non-responsive and passive to being hyper-responsive, or not hyper-responsive, hyperactive, hypermotor activity. And they can be loud, they can be agitated, they can be pacing back and forth, and that's still the same particular symptom, catatonia. Sometimes people have what we call catalepsy or waxy catalepsy, which means that an individual can be moved and put into a different position, and they tend to stay in that position, much like you might imagine doing to a wax figurine in a wax museum. People sometimes also have symptoms in the emotional side of their psychology, and we refer to this as their affect. So this includes mood swings and mood cycles or mood cycling. And we want to talk about both of these things. Mood swings, as the name suggests, are extreme changes in mood. And these changes in mood are usually considerably out of relation to the stimuli around that individual. So for example, if you're driving down the road one day and you've had a great day and you come across a terrible car accident and you are suddenly made very emotional, that would not really be thought of as a mood swing because it's highly contextual. But, for example, if you had a small argument with somebody and as a result you decided that you were going to abort your entire relationship with them and you were agitated and angry and beyond really the pale, then we would think of that as being a mood swing. People who are having mood swings are going from one extreme to the other, often with little notice, often quickly and out of context. Now, mood swings are often associated with a variety of different disorders, including personality disorders. But mood cycles are specifically identified with bipolar disorders. Now, when a person is cycling, they're going through these swings, but they're going through them in a cyclic or repeated pattern. And sometimes the pattern is not evident for many, many years because a person might cycle for 6 months of happiness or mania and then 6 months of depression or what looks to others as sadness or low spirits. And again, that may take years of happening before somebody realizes that these changes are happening in a cyclic fashion. So when we talk about mood cycles, we're talking about something where a person's mood changes really because of no other function besides the time, because of it's a period of time and perhaps because of the seasons. So mood swings can occur because of stimuli or triggers, whereas mood cycles tend to occur just because the individual has passed through a certain amount of time. So I want to make crystal clear that the person who's mood cycling is cycling between one strong mood and another, so they are swinging, but not all people who are going through mood swings are cycling. Hopefully that was clear. Now, when people get into these mood states, whether they are depressed or whether they're in the bipolar condition we talked about earlier, their moods are often what we refer to as intractable. And if you know what a tractor is, you know it's a device used to try and get traction, to try and move things that are heavy and difficult to move. And I like to use that as a way of helping to remember what intractable means. It means difficult to move, difficult to change. And if you're working with individuals who are, for example, depressed, one of the most prevalent things you'll understand is that it can be very difficult to get that person out of that mood state. And even if you get them out of it for a short period of time, they seem to continuously rebound into that state until you start to actually get them the medical, psychiatric, and psychosocial care that they need. So intractable moods refers to mood states that are very, very difficult to change. And in a way you can describe these as the opposite of that person having the mood swing, because the mood swing refers to a person with a very malleable, very easily changed mood. The person who's in the intractable mood is opposite. So they might swing into this mood and then stay there for a very long time. Some people have anxiety or panic attacks. Now, we wouldn't necessarily think of this as a mood disorder. In fact, they're clearly in the category called anxiety disorders. However, they are an emotional symptom, and that's why they're on this slide. So anxiety disorders can happen in a variety of ways. For example, a person can have what we call GAD, or generalized anxiety disorder, and this is when the person has a constant or frequent sense of moderate or mild anxiety. They never quite get away from that sense, and sometimes that moderate or mild anxiety climbs to a level of being actually severe, and it can be very debilitating for an individual. Some people, on the other hand, have panic attacks. They have episodes of anxiety where they literally are immobilized and shut down by these disembodied attacks. No particular reason why the individual is experiencing anxiety. It just occurs when it does. And for many people, they describe the symptoms as being very, very similar to a heart attack. And the person feels under tremendous pressure physically. They start to feel as though their heart is racing, their breathing is affected, and they are sometimes frozen like a deer in the headlights. So these panic attacks can become a part of a person's life, sometimes in the wake of a stressor or trauma, but sometimes they seem to occur without any particular rationale or reason as well. People can have both a combination of ongoing anxiety as well as episodes of this more severe type of anxiety or panic attack. And by the way, this is often associated particularly with one phobia called agoraphobia, which is a fear of being outside. And it's not really the fear of just being outside. It's also got a component of being socially phobic, of being around individuals and in the outside world where they have less control and where they may encounter things that are not things they're feeling comfortable with. Mania is the opposite, as we said in the last slide, of the person who is depressed. And mania refers to an individual who's in an elevated mood state. These are people who often feel extraordinarily confident, seductive, and charismatic. They may go for days without sleep. They may have a rapid flow of ideas. They may be able to speak in eloquent ways for a considerable period of time. They're often very seductive to other people. And by seductive, we don't just mean sexually seductive, although that's sometimes true as well. But they're often very charismatic and engaging for others. They seem very dynamic. They seem very energetic. They seem very confident. And because of that, people tend to actually believe them. One of the things about the person who's in the manic phase of a bipolar disorder is that people often love this feeling, and often it's when they would go off their medications. So it might seem like the manic phase in and of itself is not terribly bad, but the reason that it can be bad is that people can sometimes engage in very self-destructive behaviors, such as draining their bank accounts, or quitting their jobs and moving away, or having sex, especially unsafe sex, with a variety of partners. Sometimes people can actually become somewhat psychotic and believe that they're so capable in these moments that they can do things like, for example, flying. And so this becomes goes past the point of just being excited to the point where the individual is losing touch with reality. Many people become irritable, and that irritability can transcend many of the things we're talking about. It's probably no surprise that we would expect to see the irritability in a person who's depressed, but it also can be in the case of the person who's manic. These people may become very short with others who are normally considered to be their allies, friends, or family. And so it's an interesting thing that this sometimes means that in the moment when the person is most likely to need help, they're actually alienating help because they have a very low threshold of tolerance for others in their lives. Now, we use this term psychosis quite commonly, and we want to talk a little bit about psychosis and neurosis. You don't hear the word neurosis very often in psychological terms, but what we do hear about is something called borderline personality disorder. We'll speak about personality disorders more later on, but perhaps the most commonly talked about, the most prevalent of them is borderline personality disorder, and yet many people don't know what the word borderline refers to. And what it refers to is the idea that the person is on the borderline between psychosis and neurosis, with neurosis being the lesser of the two symptoms and psychosis being the more severe. So the individual who's got borderline personality disorder has such a acute and such a severe aberration in their personality that in some cases people may begin to have some of the symptoms of psychosis, including delusional thoughts and breaks with reality. So the person who's psychotic has a symptom that affects their perceptions. So they don't see things according to what most of us would agree is reality. They have the delusions we spoke of earlier, they have hallucinations, which are those false sensory experiences, and they have a distorted view of reality. It's common in schizophrenia, as we said, but it's also evident as a symptom in many other cases. Neurosis, on the other hand, is where a person has distorted thoughts and behavioral patterns. Now the person is still really aware of reality, but they are behaving in ways that are so out of distortion, or so out of proportion, I should say, to what we would say is normal or functional behavior, that it has a very dramatic negative effect in their lives. So for example, we might see this as a person being obsessed, being overly worried or fearful, such as phobias, or obsessed with particular individuals, as we said. And this would normally show up in obsessive compulsive disorder, and we could describe other disorders such as anorexia or even panic disorder of having moments of acute neurosis. Anytime we're talking about a person having a really significant distortion in the amount of an emotion or thought or behavior, we're starting to think about a person who's neurotic. And we don't use that expression very often anymore, but that is what it means. So let's finish up this particular video by getting you to do a journal entry, and this is review, so hopefully you do well in it. What are some of the underlying causes of mental illness? And we discussed these way back in Module 1.